Welcome to Endocrinology. We're quickly going to look at the basic anatomy. We have the major endocrine organs are your hypothalamus, your pituitary gland, who has your anterior pituitary and posterior pituitary, responsible for the anterior pituitary, responsible for your growth hormone, prolactin, thyroid stimulating hormone, luteinizing hormone, follicle stimulating hormone, and your adrenocorticotropic hormone. The posterior pituitary is responsible for storing the hormones that are produced by the hypothalamus, such as your antidiuretic hormones and your oxytocin. Then you have your thyroid glands, your parathyroid, your adrenal glands, responsible has the cortex and the medulla. Cortex produces your aldosterone, cortisol, androgen, and medulla is responsible for your catecholamines. Pancreas, responsible for insulin, glucagon, and somatostatin. Then you have your ovaries and testes. Okay, next we're going to talk about dyslipidemia. So basically, it's a metabolic disorder that is characterized by number one, elevations of your fasting plasma, low density lipoprotein. So if you're going to have an elevated fasting LDL cholesterol and or triglyceride and or low levels of high density lipoprotein. Okay. So your low density lipoprotein actually is a cholesterol rich atherogenic particles. So it's formed by further removal of your residue of your triglyceride, right, from your IDL core by the hepatic lipase. Okay, so you have your exogenous pathway and your endogenous pathway, which is biosynthesis of lipid pathway. Not really going to look into that. Then let's talk about primary dyslipidemia, which is rare. So primary dyslipidemia usually it's caused by genetic defect in the lipid metabolism, right? For one, the first one we have is you're looking at table 2 of your primary dyslipidemias is your familial hypercholesterolemia. And this one, basically the patient has an increase in your total cholesterol and an increase in your LDL cholesterol. And it's usually due to the defect of your low density lipoprotein receptor. Okay, so the receptor has a defect, and therefore, the lipids cannot be metabolized. It's also due to the defect in your PCSK9 or your ApoB, and then it's an autosomal dominant condition. It can be homozygous or heterozygous, and it impacts the liver ability to actually clear your LDL, which is your low density lipoprotein, from the circulation. So because now you have a defect in your the receptors that were supposed to take LDL into the cells, what happens is that the liver is unable to actually clear this LDL and it stays in the circulations and causes atherosclerosis. So how would the patient present? It can affect the Achilles tendon, the patellar tendon, and the extensor tendons of the hands, where the patients are going to have something called tendinous xanthomatosis. So you have depositions of this cholesterol along the joints, your Achilles joints, your patellar joints. Then you have arcus cornealis. You can also cause as xantholasmata. Okay, and the heterozygotes are usually present with premature coronary artery disease. They have 50% risk of having an MI in men by the age of 30. And the homozygous usually manifest coronary artery disease and other vascular disease early in childhood, which can actually be fatal. So usually, if you're a homozygous type, usually you present with symptoms much earlier in life. So how would you treat this? So you want to start with just your statin as your initial dose, and you can have an addition of a second drug, known as your ezetimibe, and or your PCSK9 inhibitor as a second line. Okay. So the next one is your familial combined hyperlipidemia. So familial combined hyperlipidemia has an increase in your ApoB, your increase in triglyceride, and an increase in LDL. So usually it's due to the increased production of your ApoB hundreds containing lipoproteins from the liver. So they present with premature coronary heart disease, xanthelasma, and obesity, and statin is the initial drug of choice. Then next is your polygenic familial hypercholesterolemia, where you only have an increase in your LDL. So this is a mild defect in multiple genes responsible for your LDL metabolism, such as your LDL receptor, your ApoB, and your ApoE4. So they have higher risk of cardiovascular disease, similar to familial hypercholesterolemia for patients older than 40. And statin as well is the first line of treatment. So patients, next is your hereditary chylomicronemia, right? So this has to do with an increased triglyceride from excess chylomicrons particles. All right. So your lipoprotein lipase, there's a deficiency in your lipoprotein lipase, and this prevents proper digestion and storage of fat, leading to massive accumulation of triglyceride-rich chylomicrons particles. Okay. It can also be due to deficiency in your ApoC2, and because of this deficiency, it prevents activation of your lipoprotein lipase, leading to massive accumulation of triglyceride, which are chylomicron particles. And then, so this actually present in infancy, okay, adolescent to adult, okay. And then they have abdominal complaints, pain, hepatosplenomegaly, pancreatitis, uh, lip, lipnia retinalis, eruptive xanthomata. Okay, so less than 10 to 15% of calories from fat, supplement of essential fatty acid, mm, fat soluble vitamins. So they need actually fat vitamin soluble. Sorry, they actually need fat soluble vitamins because um your lipoprotein lipase is actually not working to help in the proper digestion and storage of fat, right? So you have the chylomicrons particles that are rich of triglycerides, but because now there's no lipoprotein lipase to actually break them down to help with proper digestion, then these patients actually need fat soluble vitamins. And plasma pheresis may help individuals with ApoC2 mutation. Then the next one you have is your familial hypo alpha lipoproteinemia, where you have a decrease in your high density lipoprotein, your HDL cholesterol. So this is an autosomal dominant inheritance of a mutation in ABCA1 or the ApoA1 gene. All right, so patient present with premature atherosclerosis and cerebrovascular disease. So you need to management is to reduce the risk of your atherosclerosis with lifestyle changes. Management with uh so basically you want to manage your hypercholesterolemia, your hypertriglyceridemia, and metabolic syndrome if present. Okay, so the last one is your Tangier disease. Tangier disease where it's decrease in your HDL cholesterol. This one's an autosomal recessive inheritance of mutation of your ABCA1 gene. All right. So it's more management is the same as the previous one, your familial hypoalpha lipoproteinemia. Then you have secondary dyslipidemia, which is most common, and this is caused by acquired medical condition or lifestyle factors that affect your lipid metabolism. So start looking at table 3, looking at etiology of your secondary dyslipidemia. First column, you have your hypercholesterolemia, where it could be caused by, so hypercholesterolemia, meaning high cholesterol inside the blood, can be caused by endocrine disease such as your hypothyroidism, where you have small, dense lipo LDL with type 2 diabetes and obesity. With so basically endocrine disease, patients have hypothyroidism, type 2 diabetes, obesity. Also, patients who have renal disease like nephrotic syndrome or chronic kidney disease, where they cannot actually excrete your cholesterol, it get filled in the blood. Some patients we have immunological causes can be your monoclonal gammopathy, your hepatic causes are your cholestatic liver disease, e.g. examples your primary biliary cirrhosis. So basically the liver is not working, the ducts are not working, and then you have accumulations of your cholesterol. Nutritional anorexia nervosa. The patient is not having enough intake. Because patient is not having enough intake, the cholesterol actually supposed to break down the fat and help with fatty food digestion. And because this patient is not having any intake, you have accumulation of those cholesterol inside the bowel. So drugs such as cyclosporine, your carbamazepine, steroids, also a cause of hypercholesterolemia. Lifestyle, if you're smoking and obese, also can cause a hypercholesterolemia. Now, what are those that next column is those cause low HDL, which is your high density lipoproteins. So if you're obese, you have metabolic syndrome, you have diabetes, that decreases your HDL. And then remember, HDL is the safest cholesterol. You want to have HDL present. So drugs like beta blockers, anabolic steroid as well decreases HDL, and then other things like acute infection, inflammatory conditions. Next column, we're talking about hypertriglyceridemia, triglyceridemia. So what causes an increase? Secondary causes of hypertriglyceridemia is as your endocrine. If patients are obese, they have metabolic syndrome as well. They have diabetes. If they're nephrotic syndrome, CKD, drugs like corticosteroid, estrogen, hydrochlorothiazide, retinoid acid, beta blockers without intrinsic sympathetic actions. Your antiretroviral drugs as well, yes, they can cause hypertriglyceridemia. Atypical antipsychotics, your oral contraceptive pills, yes, they can also cause hypertriglyceridemia, so an increased triglycerides inside the blood. And lifestyle such as alcohol, high um, carbohydrate, high fat food of the fat diet, and pregnancy as well can cause an hyper and increase the triglyceride inside the blood. Okay, so these are the secondary causes of your dyslipidemia. All right. So here it says treatment effect. So for each one mole per liter decrease in LDL, it corresponds to approximately 20-25% relative risk reduction in cardiovascular disease. So the more your LDL decreases, the more reduction in cardiovascular disease. And statin lower your LDL by about 30-40%. The second line drugs such as ezetimibe lowers LDL by 18%, and your PCSK9 inhibitors lowers LDL by about 50%. But statin is actually the first line. So yes, it's 6% rule. So if the dose of statin is doubled, there is approximately a 6% increase in the LDL lowering efficacy. All right. So next, we're going to talk about dyslipidemia and the risk of coronary artery disease. Okay. So an increase in your LDL, right, is a major risk factor for your atherosclerosis and coronary artery disease, right? Increase in HDL, which is your high density lipoprotein, is actually associated with a decrease in coronary vascular disease and mortality, right? A moderate triglyceridemia. So if you have a triglyceride levels of 2.3 to 9 moles per liter, is an independent risk factor for coronary artery disease, especially in people with diabetes and postmenopausal women. So how would you screen a patient for dyslipidemia? So you screen men and women over the age of 40 years, or if they're postmenopausal women. So over the age of 40, or except they have the following risk factors that I'm going to call out. Then you can screen them at any age. So if they have diabetes, they have they currently cigarette smokers, they have COPD, they have hypertension, hypertensive disease of pregnancy, if they have obesity, BMI more than 30, okay, if their family history of premature cardiovascular disease or dyslipidemia, if they have clinical signs of hyperlipidemia such as xanthelasma, xanthomas, arcus cornelis, if they have clinical or radiological evidence of your triple A, if they have clinical evidence of atherosclerosis, if they have inflammatory disease like rheumatoid arthritis, SLE, uh, sporadic arthritis, ankylosing spondylitis, inflammatory bowel disease, HIV infections on highly active antiviral therapy, CKD, okay, erectile dysfunction, if they have high risk of patients like from South Asia, endogenous people in Canada. So those patients, all those list of patients, you screen them regardless of their age. But if they don't have any risk factors as follows, as spoken above, then you screen them from the age of 40 years old and above, or if they're postmenopausal women. All right. So screen children with family history of hypercholesterolemia or chylomicronemia. So if a child has a family history of hypercholesterolemia or chylomicronemia, you need to screen them as well. All right. So component of screening. So how would you do that? How would you screen the patients? You want to start with your physical exam. You take your history. You want to know any family history, any are they having any diseases of the above? Which are your risk factors? You want to find out any family history of cardiovascular disease as well. You want to get that. You want to do your physical exams, looking for any signs of increased cholesterolemia, as we've spoken about your xanthelasma, your xanthoma, your arcus cornelis. Okay, you want to check for any signs of hypercholesterolemia on the patients, looking at the joints. And then you want to do your lipid panel. So your lipid panel includes your total cholesterol, your LDL cholesterol, your HDL cholesterol, your triglyceride. All right. And then also your non-HDL cholesterol, blood glucose, and your glomerular filtration rate. You can also add urine, uh your creatinine levels and your ApoB. So that's optional. Okay. But then the main component of the screening is what we're speaking about, your lipid panels. First, want to take a history and do your physical examinations. All right. So your ApoB, all right, ApoB. So ApoB reflects the total number of particles and may be useful in assessing cardiovascular risk and adequacy of treatment in a high risk patient and those with metabolic syndrome. So you might want to do that. Okay. Uh, so you might also want to include your coronary artery calcium, but the main one is basically the screening component, which your physical exams, history, and lipid panel. Okay, so for statin follow up, so liver enzymes and lipids profile. So liver enzymes measured by so when a patient is taking statin, you want to measure the liver enzymes at the beginning of treatment. Then once after the therapy is initiated, so once it's stabilized, then you want to measure it annually, and then so order except if the patient presents with jaundice and right upper quadrant pain or dark urine. Okay. So CK levels. So liver enzymes. Remember, you measure it at the beginning of treatment. You can do that annually, and at any time if patient presents with symptoms of jaundice, right upper quadrant pain, and dark urine. Then patient will have on statin as well. You can do your CK creatine kinase levels at baseline. You can check your CK levels, and if the patient complains of myalgia, remember myalgia is one of the side effects of statin. Okay, and discontinue your statin if your CK is more than 10 times the upper limit of normal, or patient has a persistent myalgia. So persistent myalgia, uh, or the creatine kinase is more than 10 times the upper limit of normal in a patient that is on statin, then you have to discontinue the statin. Okay, so next we're going to talk about your cardiovascular risk assessment. So you're looking at the Framingham risk score, your FRS score. So it's basically looking at a 10-year risk of a major cardiovascular disease event. So in a 10-year, what is your risk of having a cardiovascular disease? An event of a cardiovascular disease. So basically, your FRS is calculated based on the patient gender, the age, the total cholesterol, the HDL cholesterol, the systolic blood pressure, and smoking. So if your FRS score is more than 20%, 20 and above, right, you are a high risk. If it's between 10 to 19.9%, you're moderate risk. If they're lesser than 10, you're low risk. So to check, so basically that's the first way of checking your cardiovascular risk. All right. The second way of checking your cardiovascular risk is by doing your Raynaud's risk score. Okay. So this is also 10-year risk of 10-year risk. Checking a 10-year risk of a patient getting a cardiovascular disease event, and it's also calculated based on age, systolic blood pressure, total cholesterol, HDL cholesterol, high density CRP, family history of MI. All right. Okay. So how would you now treat the dyslipidemia? So you're treating dyslipidemia based on the approach of using your Framingham risk score, your FRS score. So if the patient has a low score of less than 10, it meaning they are low risk, right? So basically these patients are actually what they need is your lifestyle modification. They need health behavioral modifications such as smoking cessation, diet. Okay, so exercise, it is recommended for adults. They need to at least have an accumulative of 150 minutes per week of moderate to vigorous, intensive aerobic physical activities. Okay. So if they're low risk, basically statin therapy is really not recommended. All right. You want to do your health behavior modification. Next, if they have intermittent risk, so meaning your FRS scores between 10 to 19.9. So and they have LDL cholesterol is more equal to 3.5 moles per liter, or the non-HDL cholesterol is more than 4, more equal to 4.2 moles, or your ApoB is more than 1.2 grams per liter, or it's a man that is above 50 is 15 above, and a woman above 16 above with one additional risk factor. Okay, such as they have a low HDL cholesterol, they have a high weight circumference, they're smoking, they have hypertension, or with the presence of other risk modifiers such as your CRP more than 2. So these patients, together with high risk patients. So high risk patient, if they have a FRS score of 20 and more and above, then intermediate risk and high risk are treated the same. So you want to discuss health. You first start with your health behavioral modification, talking about diet, smoking cessation, exercise. Then you tell them, okay, some patients can actually get better with a lifestyle modification. So if that does not improve, then you go ahead with your initial statin treatment, and then So if the LDL is more than 2, or your ApoB is more than 0.8, or your non-HDL cholesterol is more than 2.6 on a maximally tolerated statin dose. If yes, then you need to discuss an add-on therapy with the patient. All right, so you might need to add a second dose, a second line, sorry, uh, exitimab. But in all stages, you need to make sure that the patient has adheres to a health behavioral modification therapy. Okay. So here it says statin indicated conditions. So if your LDL is 5 and more, or your ApoB is more than 1.45, or your non-HDL cholesterol is more than 5.8, or this patient has familial hypercholesterolemia or genetic dyslipidemia, first remember in all cases you first start with health behavioral modifications. Okay, then you initiate with your statin. And if there's no response after giving statin, you might then consider adding a second line. Okay. Okay, so it's just to go through this diagram, but it's straightforward. It's just that it has a lot of numbers. Next, we're going to talk about disorder of glucose metabolism. So this is an overview of glucose regulations. All right. So what happens when you have an increased glucose level in the blood? So when your glucose is high in the blood, what will happen is that your beta cells of the pancreas is stimulated to release insulin into the bloodstream, right? So beta cells responsible for insulin, alpha cells responsible for glucagon, right? So as insulin is released by the B cells, what will happen? Insulin will help the glucose to be taken into the cells, all right? So it goes to the liver takes up excess glucose and it stores it as glycogen. Now what happens now when the blood glucose level is low? Your pancreas then is stimulated to release glucagon into the blood by your alpha cells. And then glucagon helps now to break down glycogen that is stored in the liver so that glucose can be released into the blood. So basically, that's the quick one. So next, we're talking about pre-diabetes. So impaired glucose tolerance or impaired fasting glucose. All right, so here it says that weight loss may improve glucose tolerance by, if you have like 5 to 10% of your body weight lost, increased risk of developing patients with diabetes have increased risk of developing microvascular complications. Lifestyle modification decreases progression of diabetes by 58%. So very, very important. Patient diabetic, lifestyle modification is always the first component, okay, for patient to actually do, because it reduces diabetes by 58%. Metformin decreases the progression of diabetes by 31%. All right. Okay. So how do you diagnose diabetes? So pre-diabetes. Okay. So any of the following. Okay. If your fasting plasma glucose is between 6.1 to 6.9. All right. If your 2-hour OGGT is between 7.8 to 11, or if your HbA1c is between 6.6 to 6.4. So this is for pre-diabetes. So diagnostic criteria of pre-diabetes. All right. Now let's talk about diabetes mellitus. All right. So what is diabetes mellitus? It's a heterogeneous metabolic disorder. So it's characterized by the presence of hyperglycemia. All right. So you have the presence of hyperglycemia. So it's chronic hyperglycemia of diabetes is associated with relatively specific long-term microvascular complication affecting the eyes, the kidneys, the nerves, as well as increased risk of macrovascular complications. Your macrovascular complications are cardiovascular disease, your stroke, your peripheral vascular disease. And diabetes also has an increased risk of heart failure. All right. So a lot of sugar affects everything: your eyes, your kidney, your nerves, your brain. Okay. So what is the diagnostic criteria for diabetes? So it's any one of the following is diagnostic. All right. So looking at table 4, diagnosis of diabetes. The first one is your fasting plasma glucose. If your fasting plasma glucose is more than 7 moles per liter, so fasting means that no calorie intake for at least 8 hours. All right. Or so any of any of this are actually diagnostic. Or you have a HbA1c more than 6.5% in an adult. Okay. Remember, your HbA1c is not, it's not a diagnostic tool for a patient that if you're suspecting a type 1 diabetes, not a diagnostic tool to be used in children, adolescent, and pregnant women. You only can use it in adults. Okay. Or your 2-hour plasma glucose. So you give a patient 75 grams, okay, of oral glucose, right? And then you check, after 2 hours, you check the plasma glucose. If that is more than 11.1, all right, that's diagnostic. Or you do a random plasma glucose and it's more or equal to 11.1 more. So a random plasma glucose actually means that it's at any time of the day, okay, without taking into consideration when was the patient last meal. All right. So how many points we have for diagnosis is 1, 2, 3, 4. So first one, fasting plasma glucose. Second, HbA1c. Third, 2-hour plasma glucose. Once the patient has been given a 75 gram of oral glucose. Random blood glucose. Right. So that's a diagnostic criteria. So in the presence of hyperglycemia symptoms, right. So if the patient has presented to you with hyperglycemic symptoms, what are those? Polyuria, polydipsia, polyphagia, weight loss, blurry vision. A confirmatory test is not required. So if they have the symptoms, okay. So in the presence where they have, in the absence of hyperglycemic symptoms, okay, a repeat confirmatory test on another day is required for the diagnosis of diabetes. So let's talk about it again. A patient comes to you, they have the symptoms of hyperglycemia, all right? Then you don't need to actually do a test to confirm it, right? Now, they come to you, they don't have any symptoms of hyperglycemia, right? But you do the test and it's positive. So what do? You need to repeat the test on another day in order for you to make the diagnosis, okay? Okay, so next looking at table 5, etiology, classification of diabetes mellitus. You have two types, right? So here we're talking about what are the causes. So diabetes, your diabetes type 1, okay? This one is an immune mediated, okay? So your own, you have a defect in your B cells. Remember, your B cells are responsible for insulin, right? So basically, disruption of your B cells, and it leads to an insulin deficiency, right? And remember, this is an autoimmune, sorry, it's an autoimmune disease, right? Yes. And if you have type 1 diabetes, you're more likely to have other types, an autoimmune disease. Okay, so autoimmune, body fighting its own self. Type 2 diabetes, so occurs when the pancreas does not produce enough insulin, or when the body does not effectively use the insulin that is produced. Then patient presents with type 2 diabetes. So what are the other specific causes of diabetes? We spoke about genetic defect of B cells function. We spoke about patients' disease of the exocrine pancreas. So disease of exocrine pancreas are your pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, which is brown diabetes. Okay, so anything that affects the exocrine pancreas, right, can cause diabetes. So a patient has pancreatitis, patient had a tumor of the pancreas. Now there's been a resection of that place, can present with diabetes. If there's cystic fibrosis, so meaning now that the functions of your exocrine glands of the pancreas cannot actually function well. All right, your hemochromatosis, when you have increased iron, that can lead to diabetes, known as Brown's diabetes. So endocrinopathy can also lead to diabetes. So endocrinopathies are things like acromegaly, your Cushing syndrome, your glucogonoma, your chromocytoma, your hypothyroidism can lead to diabetes. So drugs as well, like your glucocorticoids, your thyroid hormones, your beta-adrenergic agonist, your thiazide, your phenytoin, your antipsychotics, yep, can lead to diabetes. Infections like congenital rubella, Coxsackie, CMV, genetics. You also have genetic syndromes that are associated with diabetes. What are those? Genetic syndromes that are associated with diabetes are your Down syndrome, your Klinefelter syndrome, your Turner syndrome. Okay, this genetic disorder are actually associated with diabetes. And not to forget gestational diabetes mellitus. If a patient has that, you have high chances of getting diabetes in the future. Okay, so those are actually causes of or classifications of your diabetes. Okay. So Diabetic Canada 2028 Clinical Practice Guide says that your HbA1c need to be less than 7.0%, most adult. You want your fasting glucose. Your fasting plasma glucose, you want it between 4 to 7. Your 2-hour postprandial glucose. Okay, when you give 75 grams and then you test the glucose later, you want it to be between 5 to 10. Remember, anything above equal or above 11.1, diagnostic. Lipids, patient lipids, you want it to be, your LDL, you want it to be lesser than 2 or 50%. Blood pressure, a diabetic patient, you want it to be lesser than 130/80. Okay. So comparison between type 1 and type 2 diabetes. So type 1 diabetes, usually found in patients that are the age less than 30 years of age. Usually it's found more in Asian people, or European population. Most common in European population. Less common in Asian, your indigenous and black populations. Okay. And usually account for 5 to 10% of all diabetes. Okay, so not that much. Remember, it can be autoimmune or it can be idiopathic, so a known cause. Genetic, let's say monozygotic twin concordance. Uh, so pathophysiology. So we talk about synergistic effects of genetic. It could be with the immune, so it could be due to genetics, immune, or the environment factors that actually cause beta cells disruption, resulting in impaired insulin secretion. All right. The autoimmune process is believed to be triggered by the environmental factors. Let's say viruses, your bovine milk protein, your urea compounds. Okay, so this environmental factors actually triggers this autoimmune process into the body and leading to disruptions of your B cells. So pancreatic cells are infiltrated with lymphocyte, okay, resulting in your islet cells disruption. 80% of B cells mass is destroyed before the feature of diabetes is present. Okay, so this is more like an autoimmune process. Okay, so excuse me. So the islet cells antibody present in up to 60 to 85%. So actually, if you test this patient, the circulating auto antibodies is you are going to find your islet cells antibodies present in up to 60 to 85% of patients who have type 1 diabetes. And most common islet cells antibodies is against your glutamic acid decarboxylase. And up to 60% have antibodies against insulin. Okay. So what are the risk factors for type 1 diabetes? Personal history. If you have a personal history, if yourself you have a personal history of other autoimmune disease like Graves' disease, your myasthenia gravis, your autoimmune thyroid disease, celiac disease, your pernicious anemia. And if you have a family history of autoimmune disease, then you're at risk of having diabetes type 1. So the body habitus, they're usually normal to thin. Some of them lose weight. Okay. And the treatment for this type 1 is insulin. Acute complications they can have is your DKA. Screening, so subclinical prodrome can be detected in the first and second degree relative and those with type 1 diabetes by the presence of pancreatic islet autoantibodies. So what can you check in the blood? Remember, you can check for your islet cells autoantibodies, actually found in 60 to 85% of patients with type 1 diabetes. Uh, and then remember that your most common islet cells antibodies is against your glutamic acid decarboxylase. All right, so just these patients are usually thin or they are just of normal size, unlike patients with type 2 diabetes. So type 2 diabetes is usually found in patients that are over 40 years old of age, and increased incidence in pediatric population secondary to obesity. It's usually more common in Black people, Hispanic, indigenous Canadians, and Asian population. Accounts to 90% of all diabetes. Okay, so usually the causes is complex, is multifactorial. Okay, and then genetic, there's a greater heritability than type 1 diabetes. So you have a greater, if a patient had a family history of type 2 diabetes, there are more higher chance of having type 2 diabetes as well. So so uh so it's polygenic, it has a non-HLA associated. So pathophysiology is you have impaired of insulin secretion. So you're not secreting enough insulin. You have excess glucose production by the liver, leading to insulin resistance in the fat and muscles. And then you have impaired renal handling of the glucose. Right. So the liver the kidney cannot handle this glucose excretion anymore. Then you have impaired excretin activity. So decreased insulin production, excess glucagon production, enhanced carbohydrate absorption in the gut, and increased appetite from the hypothalamus. All right. So basically, what's happening is that you have an impaired insulin secretion, right? Because of this, excess glucose is produced by the liver. Then insulin becomes resistant. So you cannot get this glucose into the fat, into the muscles. They stay in the blood. They're trying to be excreted by the kidney, and the kidney cannot handle that anymore. And then you end up having an impaired incretin activity where your insulin production decreases. Then you have excess production of your glucagon. So glucagon, remember, glucagon helps break down the glucose that is stored in the liver into the circulation again. So you have more glucose again. So early on, glucose tolerance remained normal despite insulin resistance to beta cells compensate with increased insulin production. So as insulin resistance and compensatory hyperinsulinemia continues, the beta cells are unable to maintain the hyperinsulinemia state, which results in glucose intolerance and diabetes. So for those who don't really have circulating autoantibodies, okay, or it's found in less than 10% of these patients. So what are the risk factors? Remember type 1 we spoke about personal history of autoimmune disease. Yeah, the risk factors are if you're age over 40, if you're schizophrenic, if you have abdominal obesity or overweight, if you have fatty liver, if you're first degree relative with diabetes, if you have your hyperuricemia, if you are a black person, indigenous, Hispanic, Asian, American, Pacific, okay. If you have hypertension, dyslipidemia, you're on medications such as second generation antipsychotics, yes. If you have PCOS, if you have history of gestational diabetes or macrosomic baby, if the baby was more than 4 kg. Okay. So these are the risk factors of having a type 2 diabetes. Now, usually these patients are overweight with increased central obesity. Alright, and treatment of this type 2 diabetes, number 1, lifestyle modification. Then you have non-insulin anti-hyperglycemic agents. So unless contraindicated, metformin should be the initial anti-hyperglycemic agent of choice. Additional agent to be selected on the basis of the clinical relevance issue, such as your cardiovascular risk or EGFR or glucose lowering effectiveness. But first, initial management is your metformin. Then you can also give them insulin therapy. So what are the acute complication of type 1 diabetes? You said DKA. Type 2 is your HHS and DKA. Alright. Next, we can talk about treatment of diabetes. So first, we're looking at glycemic targets, right? So your HbA1c reflects your glycemic control over 3 months and is measured. So it's a measure of a long-term glycemic control. So when you're doing it 3 monthly, right, your A1C, so it reflects how controlled has your glucose been for that period of 3 months. So it shows long-term glycemic control. How controlled have you been in the long term? Okay, so A1C is recommended to be measured once every 3 to 6 months, right? And personalized A1C target should be set for patient based on their frailty and functional dependency and life expectancy. So it should be measured 3 to 6 months. Okay. So therapy for most individuals living with type 1 or type 2, especially younger patients, they should have a target. Alright, so the A1C should be lesser or equal to 7 in order to reduce the risk of microvascular and macrovascular complication. So more intensive glucose control, so of the A1C lesser than 6.5, maybe a target for further reduced risk of nephropathy and retinopathy. Okay. So A1C can be slightly increased in patient with iron deficiency, vitamin B12 deficiency, alcohol patients, CKD patients, independent of glycemic status. Okay, so if patients have iron deficiency, they can actually have an increase in A1C levels. And then A1C can slightly be decreased in patients who have chronic liver disease, reticulocytosis, ingestion of aspirin if they're taking aspirin, if they have vitamin C, taking vitamin C or E, or their splenomegaly or independent of a glycemic status. So this can actually decrease the HbA1c. So timing and frequency of self-monitored blood glucose is determined by the type of diabetes and treatment and the individual capacity to use information. All right. So you need to know if a patient has iron deficiency, vitamin B12 deficiency, they're alcoholic, they have chronic kidney disease. This can actually cause their HbA1c to be higher. So who should receive statin regardless of your LDL cholesterol level? Remember, if they have clinical cardiovascular disease, if they have age above 40, if they're microvascular complication or diabetes more than 15 years duration and age over 30, then they should get statin regardless of the LDL level. So who should receive your ACE inhibitors or your ARBs regardless of the baselines of the BP? So if they have a clinical cardiovascular disease, age of 55 years with additional cardiovascular risk or end organ damage such as increased albumin, retinopathy, left ventricular hypertrophy, microvascular complication, then they should get your ACE inhibitors or ARBs regardless of their BP. So going back to your treatment of diabetes, we talk about glycemic target. Number one, we say we want it to be your A1C lesser than 7 and lesser or equal than 7. Some cases you want it lesser than 6.5. Okay. And we spoke about what can increase A1C and what can decrease A1C. Next, we're talking about diet. All right. The diet. So nutritional therapy can reduce A1C by 1 to 2%. So it is recommended to intake 40 to 60% carbohydrates, 15 to 20% protein, and less than 35% fat as percentage of the total daily energy. All right. It is recommended to intake less than 7% of saturated fat, less than 10% of polyunsaturated fat as a percentage of the daily calories. It is recommended to replace high glycemic index carbohydrates with low glycemic index carbohydrates and increase fiber intake. Limit sodium, limit alcohol, limit caffeine intake. People with diabetes should adopt a dietary pattern that results in the greatest adherence based on their value and preference. Type 1. Carbohydrate counting is used to titrate your prandial insulin dose. Type 2. Weight reduction to help control blood glucose levels. Alright, so carbohydrate, but we want low glycemic index carbohydrates. Okay, 5 to 20% of proteins, less fat, less saturated fat, less polyunsaturated fat. Okay, after talking about diet, next we move to lifestyle. Alright, so losing 5 to 10% of the initial body weight can improve insulin sensitivity, glycemic control, hypertension, and dyslipidemia in patients with type 2 diabetes. So regular physical activities can improve insulin sensitivity, can help lowering your lipid concentration, and control your blood pressure. So at least you want to have 150 minutes per week of moderate to vigorous aerobic exercise, and at least 2 sections per week of resistance exercise are recommended. Okay. So smoking cessation, another one. And then you want to refer a patient to diabetic educational clinic, and they also need to have psychosocial support. Because remember, diabetes is a chronic disease, right? It's a lifetime thing. Then you can now move to, so after you've talked about diet, talk about lifestyle, that's when you can talk about medical treatment. So what are the non-insulin anti-hypoglycemic agent? These are for your type 2 diabetes, right? So you want to initiate a non-insulin anti-hypoglycemic therapy. So generally the first line is your metformin. Within 3 months, if lifestyle management does not result in adequate glycemic control. So remember, first we talk about lifestyle, we talk about diet, we talk about exercise and all that. So within 3 months, if those patients do not get well. So next we're going to talk about the treatment of diabetes. First, looking at the glycemic control or the glycemic target. Sorry. So once you have diagnosed the patient, you want to repeat HbA1c after 3 to 6 months, and then HbA1c reflects glycemic control over 3 months, and is a measurement of what long-term glycemic control. Okay, so basically we wanted lesser than 7. Okay, so in more intensive glucose controls, HbA1c should actually be lesser than 6.5%. All right, in order to decrease nephropathy, retinopathy. All right. So first we want to looking at the target of your HbA1c, okay? And then next we're looking at diet. So the first thing actually that you want to manage in a patient with diabetes is their diet. You want to make sure that are they having a proper diet, because nutritional therapy can actually reduce the HbA1c by 1 to 2%. So it is recommended to actually have an intake of 40 to 60% of carbohydrates and 15 to 20% proteins and less than 35% of fat, all right, as a percentage of your total daily energy. Okay, so it's actually recommended that patients should have less than 7% of saturated fat and less than 10% of polyunsaturated fat as a percentage of your total daily calories. So it is actually recommended to replace, so when we're talking about carbohydrates, we want to replace high glycemic carbohydrates with low glycemic carbohydrates and increase the fiber intake. So, and then limit alcohol, sodium, and caffeine intake. People with diabetes should adapt a dietary pattern that result in the greatest adherence. So basically, you have to work together with the patient when it comes to the diet. All right, so that the patient is able to adhere to this change. All right, so for type 1, carbohydrate counting is used to titrate your brandial insulin dose. And for type 2, your weight reduction to help control your blood glucose level. All right, so diet is very important. Okay. Next is the lifestyle. All right, so losing about 5 to 10% of the initial body weight can actually improve insulin sensitivity, glycemic control, and hypertension, and dyslipidemia in patients with type 2 diabetes. So it's very important. So what is the recommendation? To have regular physical exercise. All right, it says it can improve insulin sensitivity, it can lower lipids concentration, and control blood pressure. So you need to at least have 150 minutes of exercise per week of moderate to vigorous aerobic exercise, and at least 2 sessions per week of his resistance exercise are recommended. All right. And then other lifestyles is smoking cessation. You need to refer the patient to a diabetic education clinic. Obviously, they need to educate them about how they should take care of their feet, how they should, the type of shoes they should take to wear, excuse me, so and so forth. All right. Then psychosocial support is important because this person has been diagnosed with a lifetime disease. So you want to you want to have that psychosocial support, all right, so that they're able to adhere to the treatment. Now if all of this, your diet, your lifestyle is not working, then you need to look into medical treatment. All right, so for type 2 diabetes, we are looking at non-insulin antihypertensive anti-hyperglycemic agents. All right, so it says here that initiate non-insulin anti-hyperglycemic therapy. Okay, generally metformin is the first line. So within 3 months, if lifestyle management does not result in adequate glycemic control. All right, so if you do diet and lifestyle and the patient does not get better, then you want to starting with insulin within 3 months. All right. So the other for type 1 diabetes is going to be insulin. So insulin is used for type 1 diabetes at onset. All right. So for type 2 diabetes, you can wait for 3 months, starting with lifestyle modifications and diet. But for type 1, you're starting with insulin from at onset. Okay. So insulin may be also used in type 2 diabetes at any point in the treatment. All right, so you're starting with your metformin, and maybe later on the patients that still not improve with metformin alone, then later on you might need to add insulin. So the route of administration of insulin is subcutaneous injection. You also have something called continuous subcutaneous insulin infusion pump, and you can also give an IV infusion. So for IV infusion, you only give your regular insulin only, like Actrapid, right? All right. So for IV infusion, you only give regular insulin only. Okay. So you have basal insulin, okay, to control the blood sugar. So basal insulin to control the blood sugar. So it's produced by the liver during a period of fasting, and it's slow onset of action, and it's long acting. Sorry. So you have basal insulin, right, which is long acting and it has a slow onset, and you have bolus insulin, right, which is has rapid onset, okay, and then has short acting. So it's a bolus, it's quick. All right. So bolus insulin actually required to dispose of glucose from a meal, all right, to blood glucose correction. So it's quick, all right. Then your basal insulin, which is slow acting. Yes, slow onset, but then long acting. Sorry. Okay. So just before we leave the slides, here it says who should receive statin regardless of the LDL cholesterol level. So if a patient has clinical signs of cardiovascular disease, they're age over 40 years old, they have microvascular complication, they have diabetes for more than 15 years of duration, and they're over the age of 30, this patient need to receive statin regardless of the cholesterol level, the LDL cholesterol level. All right. So who should receive ACE inhibitors or ARBs regardless of the baseline of the BP? So if these patients have clinical signs of cardiovascular disease, they have age over 55 with an additional cardiovascular risk factor or an end organ damage like uh, albuminuria, retinopathy, left ventricular hypertrophy, or if they have microvascular complications, regardless of the BP, you start in on ACE inhibitors or ARBs. All right. So what are the A, B, C, D, E, S of diabetes K? So A stand for number one is your target. You want to have an A1C target of less than 7%. You want to have a blood glucose of less than 130/80. You want to have cholesterol, your LDL cholesterol of less than 2 moles per liter. You want to have drugs, D for drugs for cardiovascular risk reduction, E for exercise goals and healthy eating, S for smoking cessation, another S for screening for complications, another S for stress management. So this is your ABCDs of a diabetic case. So whenever you are seeing a patient, you want to you use those mnemonics that okay, I need to make sure that I target my A1C. I need to make sure that the blood glucose is controlled. All right. All right. What are the drugs that I can give this patient to reduce the risk of cardiovascular disease, like ACE inhibitors? Need to make sure this patient exercise, eat healthy, stops, have a good lifestyle, stop smoking, screen for complications, macrovascular, micro and macrovascular complications, and in stress management. All right. Okay. So moving to the next slide. Okay. So actually, this diagram shows us what are the factors that actually lead to hyperglycemia. All right. So what happens? You have all the factors starting from kidney. All right, so starting from the kidney, you have increased glucose reabsorption. So the kidney causes an increased glucose reabsorption. If glucose is reabsorbed, then it's reabsorbed into the blood, then it causes hyperglycemia. Now, the muscle, you have decreased glucose uptake. All right, so there's not enough insulin, so the glucose is not being taken into the tissue. So therefore, you have decreased glucose uptake. That increases hyperglycemia. Your brain as well. If you have neurotransmitters that are dysfunction, okay, that will cause hyperglycemia. Your intestine. Now, if the intestine have a decrease in incretin effect, all right, decrease in creatine effect will increase hyperglycemia. Adipose tissue increase lipolysis, the breakdown of fat. It will increase hyperglycemia. Your liver, if you have increased hepatic glucose production, okay, then you have more breakdown of glucose. This in the liver, this will cause hyperglycemia. And then the islet alpha cells, if you have increased glucagon secretion, all right, that will cause hyperglycemia. And your pancreas, if you have decreased insulin secretion, obviously would increase hyperglycemia. All right. So basically, those are the factors that increase hyperglycemia. So now we're looking at the next diagram. So what we're seeing is that how can we treat how different drugs actually work. Okay, for this one is mostly for your type 2 diabetes. Okay, so on the kidney, remember up here we said that an increased glucose reabsorption is what we call hyperglycemia. So what drug can we actually give patients? All right, so that we're not going to have reabsorption of glucose. Okay, so what are those drugs? Those drugs are called your SGLT2 inhibitors. All right, your your SGLT2 inhibitors. So we stand for your sodium glucose transport protein 2 inhibitors. So they are your sodium glucose transport, okay, protein 2 inhibitors. What happens is that it causes increase in urine glucose secretion in the kidneys. Okay. All right. So it increased glucose secretion. So glucose is actually able to go through the kidneys, pass through the kidneys, and it's not being reabsorbed. An example of this, your sodium glucose transport protein two inhibitors are actually number one is your the starting first one here will be empagliflozin, dapagliflozin, ganagliflozin. All right, those are the three types of your SGL2 inhibitors. Okay. Next, we're looking at the muscles. All right. So if what drug can we actually use? All right, to help with increase of intake of glucose. So to help the muscle have to take more glucose in. Those drugs are your bigonite and your TZD. So TZD stand for your Tizo, Lidin, sorry, this names, Lidindiones. Oh my god. So for short TDZ. So TZD, all right. So this TZD and your biguanide will actually help the muscle to uptake glucose. And then example of your TZD, TZD is your pyoglycazone and your rosyglycazone. All right. Okay. Okay. So next, remember the intestines. All right. You what happens is that you have decrease in creatine effect. If you have decrease in creatine effect, that causes increase in hyperglycemia. So what do you want to do in the intestine? You want to block what your free fatty acid absorption. Okay, all right, and then you want to also prevent glucose absorption. So intestinal lipase inhibitor. All right. So what are you going to give this patient? You're going to give them your alpha AGI, which is your alpha glucosidase inhibitors. So your alpha glucosidase inhibitors, right, will stop free fatty acid absorption. Because remember, increase in free fatty acid causes hyperglycemic. And then it will also stop glucose absorption. All right. So what are example of your alpha glucosidase inhibitors? Oops, I did not write that down. Okay, but you can Google that and find out what are the example of your alpha glucosidase inhibitors. Next, we're looking at the adipose tissue. All right, remember up here we say that what happens that if you have an increase in lipolysis, all right, the breakdown of fat, it will increase hyperglycemia. So we need a drug that will actually stop the release of fatty acid. So that drug is also is again your TZD. And then we say the example of TZD is your pyoglycazone and your rosyglycazone. All right. Next, we spoke about the liver, and we see that increased hepatic glucose production. We say that, excuse me, sorry for the background noise. We say that the liver what causes increased hepatic glucose production. So what drug can actually inhibit this glucose release from the liver is your biguanide. All right. Lastly, we're looking at the pancreas. The pancreas want to increase insulin secretion. All right. So what are you going to give? You're going to give them insulin, right? So basically, that's how we are going to manage this. So from the kidney to the muscles to the intestine to the adipose tissue, liver and the pancreas. Okay. Okay. So next we are going to look at management. Remember, what are we doing? We want healthy eating, weight control, increased activity. Then we start with diabetic medication. Okay, for type 2. Remember. So for type 2, initial drug, it's a monotherapy. Okay, so you're going to start this patient on metformin. Okay, so if you look down, it says efficacy of the efficacy it has to decrease HbA1c, it's high. All right, so the efficacy it has to decrease HbA1c, it's high. Hypoglycemic, it has a lower risk of causing hypoglycemia, and then it can either maintain your weight or it can cause weight loss. And then the more side effects are your GI side effect, nausea, vomiting. It can also cause lactic acidosis as a side effect, and the cost is low, so it's a cheaper drug. Okay, so you're starting with a monotherapy, metformin, and after 3 months, all right, if you don't still have if not reach your HbA1c target, you can go and proceed to a 2 drug combination. All right, so the 2 drug combination, first one year you have metformin and your sulfonylurea, sulfonylurea. So example of sulfonylureas are your glipizide, all right, glimepiride, glipizide, uh, glyburide, all right, glyburide, glipizide, glimepiride. All right, so those are your sulfonylureas. So basically, when you give those 2 combinations, what happens? So you have efficacy to decrease HbA1c, it's high with this 2 combination. Hypoglycemic, you have moderate risk of hypoglycemic. Weight, so patients with on sulfonylureas actually have a chance of having weight gain, and the major side effects is your hypoglycemia. So when you're putting patients on your sulfonylurea, make sure you're looking at they're more likely to cause hypoglycemia. Sorry. So the next second drug, 2 drug combination that you can actually use your metformin on your ZD. So TZD, this combination actually has high efficacy in decreasing your HbA1c, has low risk of hypoglycemia, has increased weight gain, and the major side effect is your edema, heart failure, all right, and the disadvantage that it's costly, all right. The next combination is your metformin and your DPP4 inhibitors. Example of your DPP4 inhibitors here you have is your sitagliptin, your linagliptin, your sazagliptin, alogliptin. So all of them are gliptin. All right. So these are examples of your DPP4 inhibitors. So it's really not that effective in decreasing the HbA1c as others, but you have low risk of hyperglycemia, unlikely to have weight gain, and really has low major side effects. Okay, but it's costly. The next one is your metformin plus your GLP-1 receptor agonist. GLP-1 receptor agonist example of your Ozempic. Sorry, Ozempic actually fall into a category that we call drug that we call semaglutide. So semaglutide has underneath has Ozempic, which is a weekly injection for type 2 diabetes. It has secondly Wegovy, which is for weight loss, and it has Rybelsus, which is a daily pill. So this all falls under semaglutide. Then you also have gelaglutide, you have liraglutide, um, ter, ter, terze, terzepatide, all right, as an example of your GLP-1 receptor agonist. So efficacy, it's very high actually in decreasing HbA1c. There's low risk of causing hypoglycemia, and then weight loss. You have a high chance of having weight loss. So if a patient that is diabetic and obese, this can actually be a very good medication for this patient because it not only is going to decrease, it will promote weight loss, it will increase your satiety, so patient feels less hungry, and then you have decrease of your blood sugar. All right. So, but it's costly. Next is your metformin plus insulin. So usually for type 2, you will use the basal insulin, all right? So it has highest risk, highest efficacy in decreasing HbA1c, low risk in causing hypoglycemia, and you have chance of gaining weight. And then the major side effects, your hypoglycemia, all right? And the cost may vary, okay? So if after 3 months, now if needed to reach individualized HbA1c target, so you have started 2 drug combination, you may proceed down to a 3 drug combination after 3 months, if still you haven't gotten your target HbA1c. All right. So remember, with all of the steps, you are still maintaining what? A good lifestyle, a good diet, right? And then 3 drug combination. So as you can see, the first one is your metformin plus your sulfonylurea plus one of the following, either TZD or DPP4 inhibitors or insulin. All right. Okay. So after you've done with your 3 drug combination, after 3 to 6 months, if the combination therapy that includes your basal insulin fails to achieve your HbA1c, proceed to complex insulin strategy, usually in combination or with 1 or 2 non-insulin agent. Okay, so you're starting this patient with multiple dose of insulin plus you instead of just giving a basal 1 dose, you give them multiple dose of insulin. Okay, so looking at the side slide says that sick day management. So if a patient is ill and is unable to maintain an adequate fluid intake or has acute decline in renal function, they should hold on to fluid medication. Mnemonic said men. So if you have renal function that is decreasing or acute renal failure and you're unable to take in fluid adequately, hold on this fluid. Don't hold on this medication. Like your sulfonylureas, uh, ACE inhibitors, diuretics, obviously no, you don't want to take that. Your direct renin inhibitors, metformin, ARBs, NSAID, and your sodium glucose transport protein 2 inhibitors. So what are the 8I precipitating decay? Okay, mnemonics 8Is. First, infection, ischemia or infarction, iatrogenic, such as glucocorticoids, intoxication, insulin missed, initial presentation, like in a patient presenting with first time type 1 diabetes, intra-abdominal process, e.g., your pancreatitis, cholecystitis. Now you cannot actually produce insulin, so now you're presenting with DKA. Or your intraoperative or peri-operative stress. Okay? So those are the 8Is. So looking at table 7, now we're looking at more on your type 1 diabetes management, available insulin formulations that are there. So we are looking at your Brendial insulin, which is also known your bolus insulin. Okay. So what does this include? So Brendial or bolus insulin, when you're talking about that, we're looking at 2 types. We're looking at your rapid acting insulin analogs and your short acting insulin. So for your rapid acting insulin, and rapid as acting insulin is your insulin aspart. All right. So the onset is quite rapid. So 10 to 15 minutes, peak about 1 hour and a half. Duration is about 3 to 5 hours. Then you have your insulin faster. Next is your insulin faster aspart. Then this one is very quick. Onset is 4 minutes. Then you have insulin Lispro. Okay. Then you have insulin glycine. All right. Then you have your short-acting insulin, which is your Humulin R and your Novalin Toronto. Okay, so those are your bolus insulin. So remember, brandial or bolus insulin, we have to type your rapid acting. Okay, aspart, lipros, glycine, then short-acting insulin, which is your Humulin R. Then we have second type is your basal insulin. Basal insulin consists of your intermediate acting, right, which is your Humulin N and your Novalin NPH, and your long-acting basal insulin, which is your insulin, detamir, or levemir, then glargine, insulin glargine, that is 100 units, then 300 units, and then your insulin degludec. Okay, so all of them have different onset, usually about 90 minutes. So the onset is slow, but duration is long, so it can last up to 24 hours, most of them. All right, then you have what is called your premix insulin. All right, so premix insulin, an example is your premix regular insulin. This one being Humulin and Novalin. Another premix insulin analogy, biphasics insulin aspart. Then you have insulin lispro, or so basically this is a mix of insulins. All right, so next we're going to talk about the acute complications of diabetes. So table 11 is basically a summary of acute complication of diabetes mellitus. So the first one being diabetic ketoacidosis. So in diabetic ketoacidosis, what do you have? You have high sugar in the blood plus acid buildup. Now remember that insulin helps what? To bring glucose from the blood, which is the plasma, into the cells. So what happens? Your blood says you have high glucose, but in the cells you do not have glucose. Okay, so the cells are hungry, okay, because there's no insulin to actually help the sugar from the plasma into the cells. Okay, so there's a deficiency or an absence of insulin. All right. So glucose is high in the blood, just to recap, but low in the cells. Okay, so the cells are starving. So what is that? The body will try to compensate to produce glucose for the cells. Okay, so now this lead to an increase on your counter-regulatory hormones. All right, to share your glucagon, your cortisols, your catecholamine, your growth hormone. So now, because of these high hormones, okay, you end up having breakdown of fat. All right, so it leads to fat breakdown so that you can have more glucose. All right, so that's the body trying to compensate this decreased glucose in the cells. So you have more glucose, and then this breakdown of fat also leads to ketones. Okay, keto acid, right, which lead to metabolic acidosis. All right, then the patient also present with your fruity breath. All right, secondary to ketones. All right, and then they also have deep rapid breathing. All right, because the lungs are trying to compensate for the metabolic acidosis. Okay, so let's start again. So you have this counter-regulatory hormones. It causes the breakdown of fats, and then this fat causes trying to increase your glucose, but has byproducts. The byproducts being your keto acid that goes and cause metabolic acidosis, and that's why the patient has this GIT symptoms. That's why they're going to have abdominal pain, vomiting. That's why they're going to have the GIT symptom because of the metabolic acidosis. Okay. So basically, DKA means high sugar plus high ketones in the blood, because now what happens is that the high sugar is in the blood, and then it gets excreted via the kidneys. All right, and then as sugar is excreted via the kidney, what happens? It water follows the sugar and electrolytes. So that's why the patient is going to be dehydrated, because as there's a lot of sugar in the blood, the kidney is trying to excrete some of it. Right. So what happens? It will follow together with water and other electrolytes. So that's why you're going to have decrease in some electrolytes and decrease in water, patient presenting dehydration. All right. So remember that potassium enters the cells when insulin is present. So when you know insulin is present, what does it mean? It means that potassium is going to be low in the cells, but it can be actually normal in the plasma. So in the blood it can be normal, but in the cell it's going to be low. All right. So basically, that's a summary of diabetic ketoacidosis. All right. So basically, that's a summary of the pathophysiology. All right, so the electrolytes we spoke about, one of them is going to be sodium. They're going to be a decrease in sodium. They can also have a decrease in potassium. Okay, and then there's going to have an increase in plasma osmolality. So what does that mean? That you have a decrease in water and increase in solid. Okay, so there's no balance. So they increase in your glucose, sodiums. Okay, those are your solids. Okay, so there's a decrease of water compared to the solids that are actually inside the plasma. So that's why it says increase in plasma osmolality. So what are the clinical features? The patient will present with hyperglycemia, all right, polyuria, polydipsia. They will present with weakness. Remember we talk about metabolic symptoms. That's why the patients going to present with GI symptoms secondary to acidosis. So they are going to have hunger, nausea, vomiting, abdominal pain, your small respirations, your acetone odor breath, which we are speaking about. Precipitated conditions. So what precipitates your DKA? All right. So if a patient has an infection, myocardial infarction, drugs can also precipitate a DKA. You see a patient that has diabetes, and then now they're having infections, or they're not having enough insulin, or they are newly diagnosed diabetic. All right. So those are actually conditions that can precipitate a DKA. Another one is your thyrotoxicosis. All right. So how would you want to manage this? So sorry, looking at the serum next. So what are you going to do? And what you're going to have in the blood? So you're going to have an increase in blood glucose. So typically 14 to 15 millimoles per liter. You're going to have a decrease in sodium secondary to hyperglycemia. So hyperglycemia leads to, so for every increase in blood glucose by 10 millimoles per liter, there is a decrease in sodium by 3 moles per liter. All right, so the hyponatremia is secondary to hyperglycemia. So normal, so you can have normal on increased potassium, decreased bicarb. So why would you have an increased potassium? So you can have an increased potassium because remember you don't have insulin to actually help potassium to enter the cells. So this potassium in the plasma is going to be high, right? But in the cells, it can be low, right? So you're going to have a decrease in bicarb, an increase your nitrogen urea. You're going to have an increase in creatinine because the kidney are working so hard to actually excrete this excess glucose, and then you're going to have ketonemia. So you're going to have ketones in the blood and ketones in the urine, all right? Because the kidney are also trying to work to excrete it. You're also going to have a decrease in phosphate, an increase in plasma osmolality, okay, which we were spoken about already. So basically, how are you going to correct sodium? So as you're giving the patient, you need to if you want to replace sodium because the patient is hyponatremic, you need to calculate the corrected sodium, all right? So it's going to be the current sodium plus, in bracket, 0.3 times the current glucose minus 5. All right, so it's your current sodium plus the 0.3 times the current glucose minus 5. Then be aware of your possible euglycemic DKA with near normal sugars in pregnancy and with those that are on anti-glycemic medications. Okay, so you will obviously let's start when you find a patient presenting to you with a DKA. First of all, you want to do your ABC. Okay, you want to do your ABCD, checking the airway, breathing, and circulations. You quickly want to actually put on your monitors, make sure the patient is stable. Then you want to do your ABG, then do your urine test, give the patient oxygen if needed. All right. So basically, you are doing NIU, so ABG. On ABG, your NIU gap, metabolic acidosis with a possible secondary respiratory acidosis. All right. So remember, you're going to have a metabolic acidosis. All right, and you can have respiratory alkalosis. That's because the body is trying to compensate. That's why you're going to have this rapid breathing, fast rapid breathing. So if severe, vomiting, dehydration, there may also be a metabolic alkalosis. So if the patient presents with vomiting a lot, then patient can actually have metabolic acidosis because of the vomiting. And the urine test that you're going to do, you're going to see positive glucose because the kidney are trying to excrete glucose and ketones. So now, how would you treat this patient? Like we spoke previously, you want to do your ABC. Are your first priority. So monitor the degree of ketoacidosis with an iron gap. So when you are monitoring a patient that is diabetic that has DKA, so what are you using to monitor this patient? You're using the N-iron gap, all right? You're not using the blood glucose, you're not using the serum ketones levels. So N-iron gap is the most important endpoint that is used to monitor the resolutions of a metabolic acidosis, all right? So that is what is used in a patient with DKA. So make sure you do your ABC. Then after you want to hydrate the patient, you want to give this patient 5 millimoles per liter, okay, times 4 hours, okay, for 4 hours, all right. Then you want to switch to 250 millimoles per hour times 4 hours, all right, of normal saline. So you're giving this patient normal saline, all right. So that is for mild to moderate deficit. All right. So if a patient presents with mild to moderate deficit, then you are keeping to 500 moles per hour for 4 hours, then 250 moles millimoles per hour for another 4 hours. But if a patient presents severe, if they're in shock, uh, what are you going to do? So shock meaning blood pressure is low, pulse is high, so you need to give them high level of fluids at this point. So you're going to give them 1 to 2 liters per hour of normal saline, right? And then you monitor them as it goes. Okay. So you can then switch to 0.45% sodium chloride once you have euvolemia. So if the patient the patient presented dehydrated, you've given them fluids, now they are euvolemic, then you can switch to 0.45%. Now continue normal saline if the corrected sodium is low or rate of fall of plasma osmolality is more than 3. All right. Then so as you are giving, remember when you're treating a patient with DKA, the factors that you have is your hydration, is your insulin therapy, is your potassium replacement, is your bicarbonate. Bicarbonate is usually not given. So we spoke about hydration. So once your blood sugar is 14 moles, you need to add dextrose, 5% or 10% dextrose to maintain your blood glucose for between 12 to 14 millimoles per liter. So after you have hydrated a patient, you can start with your insulin therapy, but remember, before you start insulin, check for your potassium. Okay, so critical to resolve acidosis, not hypoglycemic. So that's why you need to give this patient insulin therapy. Else your counter-regulatory hormones are continuously going to work. All right, and continue producing free fatty free fatty acids to which will continuously cause ketones. So you need to give this patient insulin therapy to actually resolve the acidosis. Okay, so do not use with the patient that has hypokalemia. All right, so you need to give them and give insulin only once the serum potassium is corrected to more than 3.3 millimoles per liter. So if it's lesser than 3.3 millimoles per liter, first adjust the potassium before you start with the insulin, because insulin will cause potassium to enter the cells and you'll have low potassium inside the plasma, and then you know what it can cause. It affects the heart, right? So maintain. So what are you going to do for insulin therapy? You need to maintain on a 0.1 unit per kg per hour of what insulin are you giving? You're giving regular insulin, all right? Because remember that regular insulin is the only insulin that you can give IV. All right, so you give an infusion, you maintaining on a 0.1 unit per kg per hour. You put it in a bag of normal saline, and then you run it as an infusion. And then you need to check the serum glucose hourly. The moment the blood glucose is 14, remember to now give the patient dextrose. All right. So now I'm going to potassium replacement with insulin administration. Hypokalemia may develop. So if your serum potassium is less than 3.3 moles, all right, just to recap, what are you going to give? You're going to give 40. Okay. 40 MEQ per liter of potassium replacement, and hold insulin until the potassium is more than 3.3 millimoles per liter. So now when the potassium is between 3.3 to 5 millimoles per liter, add your potassium chloride 10 to 40. Okay, because you want the range to remain like that. Okay. All right, so what are we giving to replace potassium? Is your potassium chloride. All right, when it comes to bicarb, so if your pH is lesser than 7, so meaning the patient is very acidotic, or if hypotension, or they're having any arrhythmias, or they're having any coma, so what do you do? And is present, if any of that is present, you can actually give bicarb 1 ampule, which is 50 millimoles, in a 200 moles of 5% dextrose or sterile water if available over 1 hour, and repeat 1 to 2 hours until the pH is more than 7. So what are we saying? We are saying if pH less than 7, or if they have hypotension, they have any arrhythmias, they're having any coma, then you need to give them bicarb. All right, you just don't give bicarb. Okay, those are the reasons where you can actually give bicarb. Okay, so do not give if the pH is more than 7.1, because you have a risk of metabolic acid alkalosis. Okay, so can give in case of a life-threatening hyperkalemia. Okay, so what are the prognosis of DKA? We say that 1.3 to 3% mortality in developed countries actually has serious morbidity from sepsis, hypokalemia, respiratory complication, thromboembolic complications, cerebral edema, which is usually found in children. Okay, especially if you give these patients fluid too much fluid and too fast, you can cause cerebral edema. Okay, so that is for DKA. Next, we're going to talk about your hyperosmolar hyperglycemic state. All right, so this one occurs more in type 2 diabetes. All right, for this one, you have increased sugars, but you do not have acid buildup. So why don't you have acid buildup? It's because you do have some form of insulin. So it's not like in DKA where your insulin is absent. So in AHS, you have some form of insulin that is present, but it's just not enough. So what happens? Fat is not broken down, right? But glucose keeps rising, right? And then what happens? You're going to have extreme dehydration because the glucose keeps rising, and then the kidneys are trying to excrete that glucose. As it continues trying to excrete that glucose, what do you have? Water and your electrolytes that flushes out to the through the kidneys as well. All right. So what happens? You have hormonal imbalance. So high ratio of counter-regulatory hormones. So you also going to have an increase in them, your glucose, catecholamines, cortisols, and growth hormones. And then what happens is that the difference here is that you have extreme hyperglycemia, so lack of effective insulin and excessive glucagon spike causes hepatic glucose output. All right. So through gluconeogenesis. All right. So remember, glucagon causes an increase in your hepatic glucose. All right, the glucose that has been stored in the liver. All right, and then so just to recap, more occurs in type 2 diabetes and often precipitated by sepsis, stroke, IM, myocardial infarction, congestive heart disease, failure, renal failure, trauma, drugs such as your glucocorticoids, your immunosuppressant, your phenytoin, your diuretics, dialysis, recent surgery, burns. All right, so those are the precipitated conditions that can actually cause a patient to have AHS. So what happens? You're partial or relatively insulin deficiency. So it's not a total insulin deficiency. So if so what it causes decreased glucose utilization in the muscles, because what happens? Glucose cannot enter the cells and the muscles, for example, the muscles. So um so while inducing hypergluconemia and hepatic glucose production, so basically that's what happens. So because you have no glucose into the cells, you have activations of your hepatic glucose production. The presence of a small amount of insulin prevents the development of your ketones, okay, by inhibiting lipolysis. All right. So AHS is characterized by hyperglycemia. Number one, they're going to have hyperosmolality, okay, and dehydration without ketones. So that's the characteristics. So more severe dehydration compared to DKA due to more gradual onset. Okay, it's a gradual onset. So it's slowly. Symptoms. The symptoms are slowly. They're not as acute. So it's a gradual onset, and you have increased durations of metabolic decompensation plus impaired fluid intake, which is common in bedridden patients. All right. So basically, what are we saying? You're saying, well, if they ask why this patient's chances of having are more dehydrated compared to DKA patients, because number one, there is a gradual onset of symptoms. There's also increased durations of metabolic decompensation. Okay. All right. So there's an increased duration of this metabolic decompensations. Plus, there's impaired fluid intake. Those patients are bedridden. They usually have trauma. They are trauma patients. They are maybe passing dialysis, or they have recent surgery or burns, and then they are not well hydrated. So that's why they present very dehydrated the moment they are diagnosed. So volume contractions. So volume contractions leads to renal insufficiency, which causes increase in hyperglycemia, increase in osmolality, and this causes a shift of fluid from the neurons to the extracellular fluid. All right, because remember, there's this severe dehydration. Okay, so because of this severe dehydration, the glucose, okay, and increasing your osmolality shows fluid out from the brain, out from the neurons, and so that they're going to have so that the extracellular space can have enough fluid. So it's kind of like compensation, something like that. And then this affects your neurons, and then the patient now present with coma. So that's why the patient present with coma or mental obturations. All right. This is why. So that would be the reason why. Okay, so the onset is in seizures, as we say, is a gradual onset, preceded by weakness. They present with weakness, polyuria, polydipsia. Okay, and then the history of decreased fluid intake. You have a history of ingesting large amount of glucose-containing fluids, dehydrations, orthostatic changes. Okay, orthostatic changes. You have decreased level of consciousness. Remember, we spoke about the shift of fluid from the neurons to extracellular fluids. So decreased level of consciousness, they're lethargic, they're confused, they can present comatose due to high serum osmolality. So your high serum osmolality and your high glucose drags fluid inside, drags fluid from the neurons into the extracellular space. All right. Okay, so yes, so the patient also has the cosmal respiration. Sorry, actually are absent. Okay, the cosmal respiration are absent. Remember, the patient does not have acidosis. They're not in ketoacidosis. So it's usually cosmo respiration are usually absent. The underlying precipitant has, except the underlying precipitant has also caused a metabolic acidosis, but usually they do not have metabolic acidosis because you do not have the breakdown of your fat, of your free fatty acid that causes ketones that later on causes metabolic acidosis. All right. So remember we spoke that in the serum you're going to have a very increase in blood glucose, typically 44.4 to 133.2 millimoles per liter. So now in mild dehydration, you may have hyponatremia, because remember what we said, that for any patient having for any glucose, any increase in glucose by 10 millimoles, you're going to have a decrease in sodium by 3 millimoles. Okay. So if dehydration progresses, you may get hyponatremia. All right. Why are you going to get hyponatremia? You have decreased fluids. Okay. Decreased water. So there's no balance. The solids. That's why you're going to have increased plasma osmolality, because you don't have you have decreased fluids, but the solids are either the same or higher. Okay, so ketosis usually is absent or mild if starvation occurs. Repeating again, increased osmolality, secondary to dehydration. So you do your ABG, metabolic acidosis is usually absent unless the underlying precipitant leads to metabolic acidosis, usually lactic acidosis in myocardial infarction. Why do you have lactic acidosis in myocardial infarction? Because cells die. So when cells dies because of lack of oxygenations, they release lactic acid. All right, so in the urine, you're going to have an increase in glucose, but you're going to have negative ketones. Okay. Treatment, remember we do your ABC, same as resuscitation and emergency procedure as DKA. You do your ABC first priority. Then hydrations first. You want to give them IV fluid. You want to give them 1 liter per hour of normal saline initially. You want to evaluate corrected serum sodium. We spoke about how to give them the corrected sodium. If corrected serum sodium is high or normal, you want to switch to 0.45 normal saline. Sodium chloride. All right. If the corrected serum sodium is low, then you maintain normal saline. All right. When the serum blood glucose reaches 13.9 millimoles, then you switch to 5% dextrose or 10% dextrose. Potassium replacement, less severe. So there's less severe potassium depletion compared to DKA, right? But obviously you need to make sure if your potassium is lesser than 3.3 millimoles per liter, you want to give 40, okay, MEQ per liter of potassium chloride replacement, all right? And hold the insulin. Remember, you hold in insulin until it's more equal to 3.3, okay? All right, the same as potassium replacement in DKA, right? So for insulin therapy, you need to give insulin therapy actually just to achieve it's achieved by monitoring your plasma osmolality, okay? Adding glucose to infusion once your blood glucose reaches 14, remember that, and then you switch to 0.45 sodium chloride once you volemic as the and then increase the saline concentration if falling too quickly. Okay, so mortality rate in AHS is high, between 12 to 17%. All right. Then we have macrovascular complications. So patients with diabetes mellitus have increased risk of coronary artery disease. Right. So the coronary artery disease, ischemic stroke, and peripheral artery disease, secondary to accelerated atherosclerosis. Right. So atherosclerosis is accelerating in patients with diabetes, either type 1 or type 2. So looking at the second bullet there, it says coronary artery disease. They have a risk of having myocardial infarction is 3 to 5 times higher in those with diabetes compared to age-matched control. Coronary artery disease is the leading cause of death in type 2 diabetes. Most patients with diabetic are considered high risk under the risk stratifications of coronary artery disease. So basically, there's one of the macrovascular complications. The second one is your ischemic stroke. So it says that A1C levels is a significant and independent predictor of the risk of stroke. So the higher the HbA1c, the higher the risk of stroke. Okay, so ischemic stroke. So here they're not talking about hemorrhagic stroke. Ischemic stroke because you build up in the blood vessels, secondary to atherosclerosis, and then this causes decreased flow to a certain part of the brain. Next, peripheral artery disease. So manifest as an intermittent claudifications. So they're going to present with intermittent claudification, peripheral artery disease in the lower extremities. So it can be in the lower extremities, intestinal angina. They can also have intestinal angina. They can also have foot ulcerations, secondary to peripheral artery disease. All right. So let's recap. They'll present with intermittent claudifications in the lower extremities, intestinal angina, and food ulceration. So the risk of food gangrene is 30 times higher in those with diabetes compared to age-matched control. All right. So risk of lower extremities amputation is 15 times higher in those with diabetes. So what do you do for your microvascular complications? You need to screen this patient. So you need to do your HbA1c or your A1c every 3 months. All right. You do your blood pressure monitoring. You do your lipids every 1 to 3 years. You do your resting ECG because you're looking. They have risk of having coronary artery disease. So you want to do your resting ECG every 3 to 5 years for high risk patients. Okay. So you need to screen them. So treatment. So you want to titrate your blood glucose control. Make sure that the patient blood glucose is below 130 to 80, especially for stroke prevention. Okay. So tie your glycemic control in early diabetes without establishing coronary vascular disease. So it's your blood pressure control, blood glucose control, is your lipid control. So you make sure that your LDL is lesser than 2, lesser than 2 moles per liter, or 50% or more than 50% of LDL reduction from the baseline. Okay. So statins is used in patients with clinical coronary vascular disease, patient age over 40, or either diabetics duration more than 15 years, and age more than 30, or macrovascular complications. So when do you use statin? So you use statin when a patient has clinical signs of your coronary vascular disease, number 1. Number 2, the age is over 40. Number 3, they have a diabetes for over 15 years. And they are over 30 years. So they are over 30 years and they have been having diabetes for more than 15 years. Or if they're having any microvascular complication, then you need to start them on statin. So ACE inhibitors and or ARBs in high risk patients. Smoking cessation, you want to talk about that. Healthy diet, physical activity, and maintaining a healthy weight goal. For adults with coronary vascular disease, who do not meet our glycemic target, so recommended to add an anti-hyperglycemic agent. Okay. So which anti-hyperglycemic agent is good for patients that are having coronary artery disease or coronary vascular disease? So the anti-hyperglycemic that has been found to be beneficial to and that demonstrates your cardiovascular benefits, it's what? It's your SGLT2 inhibitor, right? Or your GLP-1 to reduce, so they're good in reducing the risk of major cardiovascular events, those anti-glycemic.